Dr. Diasio is the director of the Mayo Clinic Cancer Center. He's been there since 2006. The Mayo Clinic has 3 locations you may be aware of. He works in the coldest one in Rochester, Minnesota. He literally has written the book on clinical pharmacology, or at least some chapters in certain textbooks. And his research has been continuously funded by the National Cancer Institute for almost 40 years. So I guess since you were like 10.
Makes me sound really old.
Right, yeah. He's been on the editorial boards of various medical journals, held a lot of leadership positions in academia, and his current interest is on genomic biomarkers that help to predict the effects of chemotherapy. And I guess that's part of what you'll be talking to us about today. So appreciate it very much. And I'm going to turn it over to you.
Thank you so much. Well, it's a pleasure to be here. I really enjoyed having an opportunity to informally meet many of you last night, and also to get involved in the discussion. I thought it was really very interesting questions, and I was very impressed by a number of the topics that came up, and I'll look forward to this morning's presentation and interaction. I guess I'll use the podium since we have one here. As was just mentioned, I've been around in the cancer world for almost 40 years. I began my training actually in medical oncology. But in addition to medical oncology, I've always had sort of a double career, one in pharmacology and involving drugs, and particularly drugs in dealing with cancer, particularly chemotherapy, but also some of the agents that are used to help manage some of the side effects of chemotherapy. And more recently, really, the influence of genomics and how genetics and genomics really help us have a better idea how to use drugs better. And so my own personal research, which I'm not going to talk a lot about actually, but I'll be happy to answer questions, involves really how we use drugs better. This has really changed tremendously with the advent and the discoveries in terms of genomics. I'd like to start, though. I was given the title of the changing landscape of cancer therapeutics, and I think that to put that in perspective is really to go back and remember where we've come from. And really the beginning of cancer therapy, if we leave out hormonal therapy, which again we can come back to a little bit later to discuss if there are any specific questions. But the beginning of cancer chemotherapy really probably dates back to World War I and the exposure of soldiers to mustard gases, and the recognition by pathologists that one of the major side effects of using mustard gases was lymphocytopenia. The spleens basically dried up, and in the patients or soldiers who ended up having autopsies, all of the lymphatics seemed to disappear in these otherwise healthy, normal soldiers that had been exposed to mustard gases. And again, I think, and one of the things I really want to emphasize today is the importance of how we've evolved in terms of our understanding of science. It was the recognition by a pathologist who described this finding that led to, really back in the mid-1940s, the birth of modern cancer chemotherapy with the use of a mustard derivative agent, a nitrogen mustard, which was used really to treat the first patient with lymphoma. It was a patient who had failed radiotherapy. At my alma mater, Yale Medical School, Goodman and Gilman, who were actually the founders of the major textbook in pharmacology, made the astute observation that this worked to cure lymphomatous disease in an animal model. And in the days when it was very easy to move from animals into the clinic, they went quickly into this patient who had failed radiotherapy, and sure enough, the patient responded and had a prolonged response, not a cure, but a more than a year response when otherwise the patient would have been expected to have died within a month. So it was a major beginning, I think, for the beginning of chemotherapy, and it was followed shortly later by the observation at Massachusetts General that individuals who, and it was really in the children's division of Mass General and the Harvard Children's, that the observation of a pediatric oncologist who was interested in helping patients to support them, and a note that many of these patients had megaloblastic anemias, very characteristic anemia. When you look at it under the microscope, one can see red blood cells that are very large and have very distinct patterns. And in order to help those patients, he started them on folates. And we talked a little bit about clinical trials last night and how we learn from each clinical trial we've done. Ideally, that really influences where we go forward in terms of the future. And this was unfortunately a negative clinical trial, and we talked last night about some of the negative implications that can come from clinical trials and the unwillingness of that particular oncologist that was noted, who didn't want to talk about the findings, which is one of the things that we don't want. We want to learn from each trial, even if it's negative. And in this particular case, unfortunately, with treating pediatric patients with leukemia, they had given them folic acid, and lo and behold, they advanced and accelerated the mortality of these leukemic children. But it led to an observation and a discovery of the beginning of antifolates, basically compounds, again, the drug methotrexate, which looks like folic acid, but is significantly different, nevertheless, in its structure, to interfere with one of the major folate metabolizing enzymes. And so that was sort of the beginning of modern cancer chemotherapy in the 40s, then followed a little bit later in the 50s by methotrexate. And we've had a number of agents that have evolved over the last several decades. But perhaps the really modern period of cancer therapeutics has been just in the last several years. And I would include three major areas. One is the onset of targeted therapy, and targeted therapy really refers to the use of the recognition of receptors on the cell membranes of tumor cells, ligands that bind to those receptors, and the development of modern monoclonal antibody technology that has allowed us to develop drugs, and you've heard about many of them, Herceptin in breast cancer, drugs such as bevacizumab in colorectal cancer, that have really revolutionized the treatment of targeted therapy. But the two that I want to focus on today are immunotherapy, and really the modern age of immunotherapy. And the second is the continued advances in genomics. Admittedly, and I gave the disclosure that my passion actually has been in genomics and how it affects prediction of drug effectiveness. But I think we can say that we're on an increasing slope of learning more and more about how genomics allows us to predict how to use the drug most effectively in treating a particular tumor. And so I'm going to spend most of the time today to really discuss those two aspects, the advent of immunotherapy and the advances in genomics and how it affects our cancer therapeutics today. And we're in a very challenging time, and I would put a pitch in. I've been fortunate enough to have funding. It's hard to believe, almost 40 years. That makes me really feel old. But I think nevertheless, it needs to be emphasized that we're in a very, very critical time. Having spent time up the road on Connecticut Avenue going toward Wisconsin at the NIH, we're in a very critical time with NCI funding, NIH funding, for really helping us to make and advance these discoveries. Now, one can say that it's just another scientist whining about more money needed for research, but we've really gotten tremendous benefits, and yet we're being very, very limited right now in terms of how we can do clinical trials as well as just basic science. It's become incredibly competitive, particularly for young scientists that are coming into doing research in this very, very important area. And it's not that we've failed in the last few decades. We've done incredibly well. But again, other pressing concerns, not to say that they're unimportant, but they really have limited our ability to work effectively as we might be able to in terms of moving this field ahead even faster. Now, being asked to talk here today, I thought it was interesting because we've had two events in the cancer calendar, one that occurs just before this meeting, or actually it's just still going on. That's the American Society of Hematology, which is meeting this week in San Francisco. And the meeting that will be later this week, starting on Wednesday, in San Antonio, the San Antonio Breast Cancer Conference that's held each year. And both of those meetings are very important, as are the American Association for Cancer Research meetings that Marcy is involved with, and the American Society of Clinical Oncology. But I'm going to sort of center on a few presentations that just came out of that, as well as some of the presentations from my own institution. You'll forgive my bias, but I'm going to use it as an example because I know that best, and I think it illustrates the broader concepts of where we're making discoveries that really count. And at the American Society of Hematology, just this past weekend, and simultaneously published in the New England Journal, we had actually 5 of 8 papers. It was fascinating to see this in a broad area of medicine. 5 of the 8 original articles published in the December 6th issue of the New England Journal focused on new cancer therapeutics and discoveries that were being made. And they all basically illustrate, again, discoveries that have been made in both immunotherapy and in the area of genomics and how genomics affects cancer treatment. And the 2 that I'm going to mention come from my own institutions, and again, were both presented at ASH this past weekend. The first has to do with a very important concept in immunotherapy called the PD-1 inhibitors. And PD refers to programmed death. And it's really how we've understand immunotherapy a lot better. Now, over the last few decades, immunology has evolved, and we've become aware of antigens and antibodies, antigens on the tumor sites, antibodies that can be developed to treat those specific antigens. But we've also become aware of other more sophisticated aspects of immunology. For example, how tumor cells that otherwise can be eradicated by normal host mechanisms. In other words, just like when we have a bacterial infection, we have white blood cells that will take care of wiping up the bacteria that are present. We also have cells like macrophages and T lymphocytes, activated T lymphocytes, that are set up to really destroy tumor cells that are present within the individual that has cancer.
Dr. Diasio,
Yeah.
can I ask you,
Sure.
a couple people in the back are having trouble hearing.
Okay.
So we have 2 choices.
Okay.
You can pick up that mic and speak into it. You
Sure.
can, or you can sit at the table and put the mic in front of you.
Would it be easier if I'm at the table? Or?
It's totally up to you. Yeah.
No, I don't think I can get over there with this
I
microphone.
think Raina can fix that. I hope Raina can fix that.
Yeah, I can fix it.
Okay.
It's definitely long enough. It's just a lot of things.
Great. Thank you
Sure.
so much.
No problem.
Closer to you, it's, yeah.
Okay. All right.
You don't have to hold it if you're at the table.
Yeah.
Okay, how's that? Can you, great. So I think part of this has been really the evolving aspects of immunology, and we've learned a lot more in terms of how immunity actually works in cancer. And by understanding the processes better, we've been able to design more effective therapeutics. So with the programmed death pathway, we now understand that this is a pathway by which many tumor cells find a way to escape the effect of activated T lymphocytes. I'll get down here close. But the activated T lymphocytes are actually, as I said, so important in terms of really wiping up the tumor that's present. So what we would like to be able to do is to be able to deactivate the process by which the tumor escapes the effect of the individual mechanism in the programmed death pathway that allows it to work more effectively and alter the effect of the tumor response. And so what's happened is that there's been a lot of development of new agents that actually work to go against this programmed death pathway, and particularly called PD-1 inhibitors. And this past weekend, we had an example being presented. Again, it was a multi-institutional study, a number of institutions led by Mayo Clinic, but involving Dana-Farber, involving Memorial Sloan Kettering. And it was basically a study in which they looked at Hodgkin's disease, a very common disease in young people, and found that the cells that are very common in Hodgkin's disease, the Reed-Sternberg cells, actually can secrete PD-1 ligands that can actually stimulate this programmed death pathway to interfere with basically the tumor immune response by activated T lymphocytes. I know that's a lot to sort of comprehend, particularly if you're not used to it, but basically we're disabling the machine that allows the tumor cells to basically escape the effect of that occurs normally. So by using an antibody that works against these PD-1 ligands, and we're fortunate because we have a drug, actually several drugs, that have been developed in the past few years. One of them, nivolumab, is an antibody that actually targets these individual ligands. And it was shown that in these patients that have Hodgkin's disease, they did much better after being treated with this. And so it's felt to be a major step forward, very similar to what was developed with melanoma, and many of you have heard about, again, a disease that previously, in its most advanced stages, where surgery cannot eradicate the disease, melanoma now is very responsive to many of the same type of agents that interfere with the immune escape mechanisms that tumor cells have. And so it's a major step forward. It gives us another type of therapeutic to use in Hodgkin's disease, and we really feel that though we've made many gains in Hodgkin's disease, and it's one of the diseases that we potentially can cure, we feel that having this additional agent, which works not only in Hodgkin's disease, but also, like I said, in melanoma and many other tumors, represents a major step forward. The other presentation and publication in the New England Journal this past Saturday that came from Mayo was a new drug for treating multiple myeloma. Again, this is the American Society of Hematology focusing on hematologic malignancies and Hodgkin's, again, in young adults, and multiple myeloma that occurs in people of all ages, but particularly individuals in the older decades of life. As one gets older, myeloma, the risk of myeloma can increase. And we had a very important study presented by one of the Mayo hematologists, actually from Mayo Clinic, Arizona, that described the use of a new drug, a drug called a proteasome inhibitor, combined with two other agents, dexamethasone, which is a steroid, and a drug called anilimide, which has been shown to be very effective as an immunomodulator, also very much like ipilimumab, which is used, the agent I talked about in melanoma, that affects the PD-1 pathway. And this has made a major gain, moving the median survival rate in a study of about 800 patients from literally all over the world, from about 17 months in heavily pretreated patients to now up to about 26 months. So it's, again, a major gain. And when I say major gain, sometimes people, those of you that are cancer survivors appreciate what I think I'm saying. We've learned so much and we've gained so much over the last several decades since nitrogen mustard and methotrexate were evolved, that we've added more and more agents. And again, by adding the additional agents, we've really prolonged response, and we've gotten overall survival to increase dramatically in a number of diseases. And we talked about last night that there's some diseases, when I finished my training as an oncologist, were virtual death sentences, hepatoma, renal cell carcinoma, malignant melanoma, particularly in the advanced stages, not the limited stages where the disease can be surgically removed quite easily in the early stage, but in the advanced stages where it's really very, very difficult to accomplish a cure. But with each step, we've made, and the introduction of new agents, we've really had major increases in survival, and it's been in virtually the whole array of diseases, from hematologic malignancies to the major solid tumors. Toward the end of this week, as I mentioned, we will have the San Antonio Breast Conference, and San Antonio is very, very important each year for presenting new studies, particularly in breast cancer. Although AACR, the American Association for Cancer Research, and ASCA, the American Society of Clinical Oncology, their annual meetings are sort of the premier meetings for presenting new science in cancer. Both San Antonio for breast cancer and ASH for hematologic malignancies have been two very important meetings that sort of are in the other season rather than being sort of in the May to June period. They're in the December time frame of the calendar. And I cannot talk because of embargo, and I will respect the embargo that's on publications and abstracts being presented there. But I would talk about sort of peripherally some of the work that will be going into studies being presented there. And both, and in this case, I'm going to switch from immunotherapy to genomics. And we've had so much new information evolve in terms of genomics. In breast cancer, we've learned that we can make a very good choice. And I'm going to just stop here for a second and say, and I think I talked with one of you last night about the 4 big malignancies, and when we talk about prostate cancer, lung cancer, colon cancer, and prostate, lung, colon, and breast. Those 4 tumor types are the ones that occur most frequently in most patients in our population. So those are the 4 that we always think of from the magnitude perspective as being really very, very important. And in breast cancer, we've seen breast cancer is a success story in terms of many different agents have been developed over the years. Cytotoxic chemotherapy related to methotrexate, which once had a major role in the treatment of breast cancer, but is hardly used today as a frontline agent. And now we've had hormonal therapy evolved, and we've had not only hormonal therapy, but we've had anti-hormonal therapy. So we have a drug called tamoxifen, which many of you have heard of, which is very, very common in the treatment of breast cancer, particularly postmenopausal breast cancer. And we have a series of other compounds called aromatase inhibitors. Aromatase inhibitors are basically work on an enzyme reaction, aromatase, that can convert androgenic steroids like testosterone. Even women in this room have a little bit of androgen in them, and that androgen can be converted to estrogen, which can actually drive a breast cancer. So we'd like to be able to block any of the androgen that's present that can be converted by this aromatase reaction. And aromatase inhibitors over the last few years have evolved to become more and more important as the first-line treatment for postmenopausal estrogen receptor, progesterone receptor positive patients. Again, here the importance of understanding the receptors present on the tumor cell, giving us guidance as to how we use a particular therapeutic. But in the case of tamoxifen, we've also learned through genomics that some of the very common drug metabolizing enzymes, and within all of us, in our liver, we have enzymes called P450 enzymes, and they belong to various subfamilies within the P450. One particular subfamily is called cytochrome P450 2D6. It's a very complicated naming, and those of us that work with it don't think too much of the terminology, but when you hear it for the first time, you don't know what do all these numbers mean. But what happens is we know that many people differ in the population. 20-30% of our population, and in different racial groups, have different amounts of CYP2D6. And what that's led us to realize is that not all patients should be treated the same way. So the same shoe size doesn't work for everybody. The same drug dose doesn't work for everybody. And so one of the very important genomic concepts that's come up from using modern hormonal therapy such as tamoxifen is being able to use the genetic information that comes from profiling CYP2D6 to know how to use the right dose for the right woman being treated with that form of breast cancer. And it's been a very, very important concept. This has really led to a lot of work recently and throughout the country. And again, I'd make a pitch for the 68 NCI designated cancer centers that are all over the country. They're regionally well represented. The cancer centers, I think, are the locus of most of the major cancer research being done in this country. One of our major interests at present is really studying patients with breast cancer, but utilizing a new approach. As many of you know, and some of you who have unfortunately been affected by breast cancer traditionally has been treated with surgery, after which the patient, depending on the age often, but the receptor status being a major effect, whether the patient's an estrogen receptor or progesterone receptor positive, making the decision whether to use hormonal therapy or not. And then this is followed by chemotherapy in what we call adjuvant therapy. Adjuvant being really using it adjacent to the surgical approach, which has been thought of as being the main approach. But recently in breast cancer management, and really because of our success with chemotherapy, because chemotherapy by itself in a patient that has still relatively localized, not widely disseminated breast cancer, but still relatively localized breast cancer, as most breast cancer presents in this country, the opportunity to really use a totally different approach, which we now call neoadjuvant therapy. And neoadjuvant has begun to be used much more commonly, and the chemotherapy is used first. Complete eradication or near complete eradication is achieved, and this is followed then by surgery to remove the tumor. So the feeling is that many of the cells that may have disseminated at the beginning, theoretically, can be destroyed, and then one can go in and remove the tumor. And just like we're dealing with concepts like morcellation that you may have heard about, and again in the Harvard news, there's been a lot of news coming out of the Brigham about the fact that that's such a bad technique because it's spreading cancer. There's also the worry even with surgery. Surgery could spread cancer. So the idea is if we could use chemotherapy first, we can potentially have a better effect and then do surgery second. And that's what the neoadjuvant approach is. But we've evolved into a new study, and it's a study that I have to mention also is funded entirely by benefactors, grateful patients, and individuals who've been interested in funding this research. This is not a research project I'm going to talk about. In this case, I'm not talking about an actual publication that's been demonstrated with significance in the literature, but I'm going to talk about what we're doing now in the laboratory being the human laboratory of studying patients with breast cancer. We're using benefactor money, not money from the National Cancer Institute, the American Cancer Society, who would not pay for such a high-risk project where there wasn't really preliminary data to say this really works. But we're doing this to really try to find out what we should do better in the future. And we have a study that involves neoadjuvant breast cancer, and we call it, actually one of my colleagues, Jim Engel at Mayo Clinic, came up with the name Beauty, B-E-A-U-T-Y, coming from breast cancer genomic guided therapy. And if you can figure out that, I think the B, E, and A come out of breast, the U comes out of guided, and the T and the Y come out of therapy. And this is, just as a side note, is one of the problems and the uniqueness of oncologists is we come up with these crazy acronyms for our regimens to try to remember the individual regimens. So beauty seemed like an appropriate title to be used for breast disease or whatever. Jim came up with that concept. And it's been a really fascinating study because what we've done in this study is to initially treat the patients with effective chemotherapy. We've evaluated their receptor status, including not only their hormonal receptor status, but also a new type receptor, relatively new, called HER2-neu. You've heard the concept of triple negative breast cancer. Triple negative is when a patient has no evidence for estrogen receptor, progesterone receptor, or HER2-neu receptor, and that's a very, very malignant, aggressive type tumor. But depending on the receptor status, the patient will get chemotherapy plus a HER2-neu inhibitor or not. Again, Herceptin being one of the major agents being used. But in conjunction with this patient study, getting, again, basically the therapy that's the most effective therapy that one can use today. We're not experimenting with these patients, but what we are experimenting is with new techniques. So we're using, all of these patients are getting a type of imaging procedure that includes not only CT and MRI scans, but also what we call molecular breast imaging, which is a new study that will be reported soon in the American Journal of Radiology. Interestingly, it was accepted by the higher impact Journal of Radiology, but they did not want the title molecular breast imaging in the title, and the author of the study, Deb Rhodes at our institution, refused to change the title because she thought it was so important to have molecular breast imaging for indexing purposes that it would continue to be looked at as being this particular title for the procedure. But in addition, yes, Steve?
I'm just wondering, do you prefer questions at the end or along the way?
We can have it along the way, please. I don't want you to forget the question.
Okay, so I was wondering a little bit if we could learn a little bit more about these benefactors.
Oh, yeah.
And because for me, one of the questions I'm interested in is gender disparities for funding and awareness
Right.
for different types of cancer. cancers, and the prostate community
Right.
really doesn't exist in the same way. So could you talk about that and whether
Yeah,
the
no,
ethical issue is
I
involved
mean,
with
just,
it?
I mean, that's a very good question, and there is a gender bias, I think. Perhaps we, and you can tell just by the funding agencies that are out there, Susan B. Komen, many of the there are numerous ones in the breast cancer area. Prostate has lagged behind, but I wasn't planning on talking about it, but I can tell you we also have a study with the acronym PROMOTE, and PROMOTE actually is for
Beauty and
prostate.
promote?
So it's beauty and promote. So there is gender difference there, but we elected in our genomic guided therapy studies to really take 2 of the 4 most common malignancies where we felt we could make a difference. And we actually chose breast cancer because we have so many effective therapies, and prostate cancer. We didn't choose colorectal or lung cancer. I wish I could say that we're better at treating both colorectal and lung, which occur in both genders very, very frequently. But we actually, not for a gender conscious reason, but because they're 2 of the most common malignancies, and it just happened to be it's breast and prostate. But your question is there are diseases that don't get supported. Cholangiocarcinoma. They're diseases that are relatively rare, and we're becoming, as I said, more and more dependent on other sources of funding because NCI and the American Cancer Society is limited in terms of what it can do. The NIH, again, used to say one B-1 bomber could, fund an enormous amount of research.
So are the benefactors in this case like Susan G. Komen, or are they individuals?
These are
corporations?
these are individual benefactors, and interestingly has not been the major funding sources, but it's been individuals, and of course they're affected individuals for the most part, families of affected individuals who really gave money to both the beauty study and the promote study. But it's not just the gender factor, but it's also the magnitude of the disease. So we're talking about, not only
So I can't give you $10 million, $100 million,
Yeah.
and you would definitely do my study.
Yeah,
There's
no,
a-
and I mean,
there's
it's a
evaluation
good
process.
question because it's not just a gender-derived decision. And granted, there's a lot that goes to breast cancer that doesn't go to male involved cancers, like prostate cancer. So there is a little bit of disparity there, but there's also this magnitude of the occurrence of the disease. So we're talking about the 4 most common malignancies versus other malignancies that are relatively rare. So it's a very good question. But getting back to beauty, one of the things, in addition to the molecular breast imaging that we've learned from doing this study that we are now reporting on, is looking at actually genomic studies, and the genomic studies involve actually taking biopsies, and this is a study that's actually led by female surgeons. Almost all of our breast cancer surgeons at all 3 of our sites, interestingly, are female surgeons that specifically treat breast cancer. And we have a huge practice such that we have surgeons that only do one disease, and which leads to, I think, an increased level of competence. But the breast cancer, 2 of our breast cancer surgeons in Rochester, but also we have breast cancer surgeons in Jacksonville and in Phoenix, Arizona, at our other 2 major Mayo sites that are involved in the beauty study. And they have, amazingly, when I think about it, they convince these patients to contribute the time and the effort, and part of the effort is actually getting a biopsy of the tissue, not once, but 3 times, 2 times in the case of the procedure, and then the 3rd tissue sample actually comes when they finally get the surgery at the end of the chemotherapy. So at the diagnosis, they have a core biopsy taken. after they finish the first course of chemotherapy, they have a second biopsy taken. They then go to a different course of chemotherapy, so they're getting 2 different chemotherapy regimens. At the end of the second course of chemotherapy, they actually get surgery, and the surgery then allows for further studies. But with the core tissue that's obtained, that tissue is being studied for genetic markers, and it's also going into immune incompetent mice, basically what we call a PDX model. It's a pharmacogenomic diagnostic model that allows us to basically study a human tumor in a mouse and basically look at not only, and I might mention, not only current chemotherapy agents, but even more interesting, particularly to the pharmaceutical and biotech industry, is we can take those same tumor specimens, and I have to say this is the first time I've ever seen this happen in my years of being involved in drug development and going to ASCO every year when you talk to each company separately and they want to do a study with you, but they only want to do it on their drug and they don't want to hear about any other drugs. Because you're working in the animal model, and it isn't really a risk to their IP or whatever, they have allowed a number of these new drugs that are actually have not been released yet for clinical use to be looked at in the animal models. And it's led to some really fascinating observations. I don't want to spend too much time because I want to get to a couple of other topics, but I want to mention one other aspect. In addition to really using the PDX model to study individual tumor responses to current agents, and the hope is we'll be able to use the mouse to be able to predict how to use the drug most effectively in that particular patient. But the other thing that's turned out to be very interesting is that looking at the genomic pattern has also given us an opportunity to really look at the individual genes. And you've all heard the term BRCA gene, BRCA1, BRCA2. Again, we talked about Angelina Jolie, who's popularized the whole concept of, very important that she brought that out, about the fact that she happened to be in an affected family and, again, electing to have aggressive surgery done as part of her management. But BRCA is only one type of gene. It isn't just associated with breast cancer. It's associated with all kinds of cancer. It happens to be a type of gene. We have 2 major classes of cancer gene. One called oncogenes that turn the cancer on, and other genes called suppressor genes that turn the tumor off, that keep it under control, similar to the immunotherapy mechanisms that I talked about before. If we can understand this here, BRCA isn't just dealing with breast cancer, it's dealing with all kinds of cancers. And in a similar way, what we've learned from our first 180 patients that have been put into Beauty 1, which is the first phase of this study, and again, this is unpublished information, but it's been described in public meetings already, so I think I can say it and not offend the investigators, my colleagues at Mayo. But one of the really interesting aspects has been not only does BRCA occur in other tumor types, but some of the breast cancer patients, and one particular patient who happened to be a Mayo nurse who had breast cancer and was in this study, unfortunately, she had triple negative disease, which is a bad disease, as I mentioned. But her tumor grew in the laboratory. It also, and triple negative tends to grow better because it's much more aggressive. But it also, the tumor ended up having, lo and behold, a gene called DNMT. It's a methylation gene, a DNA methylation gene that is found particularly associated with leukemias. And we actually have a drug to treat that. It's a drug called azacitidine. But if you ever asked me, would we use azacitidine in breast cancer, and you asked me that question 10 or 15 years ago, I said, are you crazy? You know, and FDA would never allow us to use azacitidine, an anti-leukemic drug, in a breast cancer patient. But what we're learning as we get into genomics is that genomics is not, what it's telling us is cancer is not in a little box, and we call this breast cancer, we call this prostate cancer, we call this head and neck cancer, but they're all part of the same process. And genomics is sort of taking away the barriers. And so as we get into clinical trials, we begin to really need to change our whole approach as to how we pick therapeutic agents. We probably shouldn't be picking therapeutic agents based on a clinical trial in a particular disease that showed an effect based on this, a particular effect in this particular disease, but rather we should be seeing what happens to patients that have this particular genomic pattern, whether they're breast cancer, colon cancer, or whatever. Yes, please.
I have a question about the PDX model.
Yes.
Are you saying that if you take a biopsy of my breast cancer, you put it into a mouse,
Right.
and then you see what perhaps new drugs might work on that mouse, and then you give them to me because it was specific to me?
Because it's your
Or is this
it's
more
your
generalized
tumor.
to
It's your, it's basically, again, it's making the decision based on the individual patient and not based on the population. Everything we've done in the past has been based on the population of patients. And last night when we were talking, I mentioned, we were talking at the table, I mentioned the N of 1. Which is a new genomic concept. Usually when we talk about clinical trials, we're talking about a statistically designed study where we have our statistician colleague telling us we need this many patients. I mentioned the myeloma study. It had 792 patients in it that was presented at ASH last Saturday. The statistician told them they needed that many patients to predict significance. But as we get into genomics, significance is in that individual patient. It's the N of 1. N equals 1 for the specific patient. A patient with a specific genome basically should tell you, that genome should tell you how you should be treating that patient and not a population study of diverse group of people. And so it's moving us very much in that direction. Yes?
This is Sophia. I'm curious if genomics actually has an effect on side effects of chemo and other treatments.
Excellent question also. And yeah, I think that it very much could have a prediction because many of the drugs, for example, some of the drugs used in treating breast cancer, for example, hot flashes. You take tamoxifen. Tamoxifen basically causes it's a chemical oophorectomy in one sense. It's blocking estrogen effect. It's actually not it has the effect of a chemical oophorectomy because it's putting a key that's a mislabeled key into a lock and jamming the lock, preventing estrogen from getting into that receptor. But the effects are dryness and many postmenopausal symptoms that come, hot flashes that come as a result of estrogen deprivation. We've now learned many of these estrogen or drugs that are used to treat hot flashes, for example, are affected by the same P450 mechanisms I mentioned before, where there's a lot of genetic variation in the drug metabolizing enzymes. So genes that are responsible for, and we have, the P450 happens to be a family of genes that work on diverse drugs, tranquilizers, cardiac drugs, all sorts of different drugs are using the same mechanism to basically break down the drugs, but they're genetic differences. And so if we better understand the genetic differences, we can better understand how to use the individual drug to treat side effects in that particular patient as well. So it's very true there too. But I think it provides us guidance. Did you have a question?
Yeah, kind of off of that, I guess. I don't know if you could talk a little bit about how, whether Medicare covers this sort of testing. Kind of get into how once these things are put out there,
And
that
I'm going to get to an example of CMS and FDA a little bit later,
Okay.
so I'm going to come back to that. But a lot of what's done, what I'm talking about now is not done in general. And what we talked about last night, again, I didn't want to mention it, but then somebody came out and blurted it out and said 23andMe. There's a lot of genomic use that's being done out there that's incorrect, and it's not. And there are people that are doing it, trying to exploit scientific knowledge to promote really their own financial gain without really any opportunity to learn or help patients with it. So that's wrong, and it's not. It should not be done.
But in terms of things like, you know, an oncotype DX or other
Right.
types of genetic
So
testing.
I think there's been a recognition for, for the oncotype test, certainly for the receptor test, for the HER2 new test, for EGFR test, for some of the genetic tests like for ALK, which is a fusion gene, which used to treat crizotinib or vermorafenib, which affects a particular BRAF gene. We've had approval of both FDA for a diagnostic test and CMS has approved it for payment. But it's been, but many of the things I'm talking about are really going to the outer limit. And for example, the PDX model, that's not going to be paid for. That's totally research, but it's valuable research. And I think one of the most exciting things to me as the pharmacologist in me, aside from the oncologist, it's the interest in really looking at new drugs, not just even the drugs for that individual patient, but looking at new drugs that are 5 years from the clinic, and looking at different companies who would never think of using their drugs together in combination, which is what we do. We use drugs in combination, but using new drugs from 3 different companies and putting them together and seeing a cure is absolutely incredible. And it's gotten these companies for the first time to talk when they previously, it's IP. We don't want to involve losing anything in terms of patent rights, and they've been unwilling to, but they've been willing to work in this sort of situation. So to me, that's one of the most exciting aspects. I know I'm going to run out of time, so I want to touch on a few other aspects because I want to allow some time for questions too, because I know you have other questions. One of the other things that we've been very excited at Mayo has been the use of gene therapy. And gene therapy you've heard about over the years. There have been many different approaches. We became very excited. We have a lot of work going on with attenuated measles virus. And we have an attenuated measles virus that has a type of abnormality in it. It's called an iodide transporter, very much like the thyroid gland uses. But because it involves iodine, it allows us to actually image it. And what we've been able to do is basically follow this therapeutic virus when we inject it into patients. And this is a study that was published actually earlier this year, and it involved, and I guess I should say in this case, an N of 2, because there were 2 patients. It was sent to the New England Journal. The New England Journal said, fascinating, show us some more patients, which was an entirely appropriate thing for the New England Journal to say. But it was such an important concept because we had a woman, the first patient in the study, who was given, and we've treated patients with the measles virus at Mayo for a number of different diseases, for breast cancer, ovarian cancer, glioblastoma. But the multiple myeloma studies, again, have been potentially the most interesting. And one of the things in this N of 2 study that was done was it was given at an incredibly high dose. It was 100 million times the dose of vaccination that would be used for ordinary measles. So when you bring your kids in to get a measles immunization, they're giving them 100,000 times that dose of virus, an attenuated virus. It's not going to cause all the bad manifestations of measles. And in fact, all the bad manifestations were taken out. But the virus accumulates in myeloma cells. And it actually, when it gets into the cells, it destroys them. And in this particular case, the patient got a very, very large dose of the measles virus, and we learned so much from doing this particular clinical trial in one patient, and it's been now repeated in 2, and actually since that journal article was published, and we had tremendous response from media coverage, and now have a phase 2 study going on that's going to evaluate this in detail. But the first patient taught us that we might be on the right track to using gene therapy. And the very exciting aspect of it was that the patient had been previously treated with multiple different courses of chemotherapy over about a 7-year period. She'd had 2 different bone marrow transplants. She'd failed them. She had a huge plasmacytoma in her, coming out of her skull. She had evidence of a large spike of protein in her, coming from her bone marrow, called an M peak, as a myeloma peak of immunoglobulin. And she was basically on the way out. And she was given this huge dose of virus in an attempt to try to treat her. And lo and behold, she had an unbelievable response. The plasmacytoma, and I don't know, Sharon, if you remember the name from that article, she actually named the plasmacytoma that was growing out of her head, out of her skull, called it Eric or something like that, because it was almost like it was a pet that was growing out of her skull. Well, Eric disappeared, and all of the evidence of the disease disappeared, and it's now been 27 months after having been treated with this therapy. And as I mentioned last night, one of the things NIH is doing is really dealing with exceptional responses. So the exceptional response here were 2 different things, and 2 different things that make us really rethink gene therapy, even though gene therapy has been around for a long time. One was we followed a basic pharmacologic concept. The dose matters. I've been talking to you about how dose matters in the individual patient, but this was a gigantic dose, 100 million times the dose that's used for a typical vaccination for dealing with measles. The other thing that we learned in studying her was that she had no antibodies to the normal measles virus. Her level of immunity to get rid of the virus was incredibly low. And what we've learned in some of our other patients, who unfortunately have not responded, is that their level of antibody to the measles virus is incredibly high. So this gene therapy aspect has also now become an immunologic problem. And we're learning that if we can manipulate the immune background to prevent the eradication of the therapeutic agent that's being given and still give enormous doses. And again, these doses are manufactured at Mayo in what's called a GMP laboratory that's totally like a space age laboratory. Everything is, the viral particles are prepared there under FDA guidance. One can potentially achieve a cure. So a very, very exciting approach. I know the authors would love to have published it in the New England Journal, which is always like the pinnacle of clinical success for reporting. But I think they'll come back at a later time because we're very excited about the subsequent studies that will come from this initial study. But I think it was a very, very important agent. Yes, please.
I'm probably missing something. I'm not seeing what the mechanism of action is. I don't know anything about
Yeah, the virus localizes, recognizes receptors. I'm sorry I didn't go into it in more detail, and I would refer you to the Mayo Clinic Proceedings article to go into it in much more detail. I'm going over all of this in just a smattering because I want to sort of hit the highlights of these different therapeutic approaches. But this is an approach where the virus targets the individual tumor cell, receptors on the tumor cell that are avidly bind the virus and take the virus into the cell. But the virus, instead of causing the manifestations that measles virus usually cause, actually destroy the cell. So it eradicates the cell. And by having the iodine transporter that I alluded to earlier, we actually can image this. So we have a way of imaging it just like we image thyroid disease. Yes, please.
It must be an inactive measles.
Yes, it's an attenuated.
It's just some kind of programming error.
Yes.
You handed it an
No,
inactive
it's not.
virus,
It's not the.
somehow the cell
Yeah.
takes it in. And
It is a virus called the Edmonton variety of. It was isolated in Edmonton, Canada, and it is a special attenuated version of the measles virus that loses many of the characteristics of the virus, but has enough of the characteristics that still is a measles virus, but it doesn't cause the, let's say, the clinical manifestations of the disease measles. But it targets these tumor cells because it targets receptors. And it happens that myeloma cells have a very high percentage of these receptors on the surface. And it's one of the reasons why we feel that it's been most effective there. And it was the reason the disease was chosen as the initial choice and not some of the more common diseases.
You mentioned that she had no antibodies to the normal measles virus, but some of the other patients did, and they didn't have as good of outcomes. Did you guys look at whether or not they'd had previous vaccinations, or was that?
Yeah, absolutely, absolutely. A very good question, and that's being looked at. But not only are we looking at that, but we've learned that some of these patients that never had measles, never got the measles virus, still had enough of exposure, never had clinical measles as a child, or at least couldn't remember it. Nevertheless, had antibodies present. So we need to look for the antibodies in the serum to really predict the immune status of the patient.
Would you then try to suppress the immune system?
Yes, and that's exactly, you got the immediate target for the future, just sort of like the PD-1 aspect that I was talking about. What we're doing with the PD-1, the tumor learns, in a sense, to deal with disabling the mechanism that had evolved to eradicate it. So basically, as with PD-1, there was a mechanism that the tumor basically adapted. It didn't learn, but it adapted to basically dealing with the programmed death mechanism. It disabled it, and thereby it was not being able to be eradicated by activated T cells. And it's a very, very similar situation with the measles virus that we're talking about. We're talking about, and what you're suggesting is actually a therapeutic approach. So if we see people that have an activated immune response to the measles virus, can we go further in the future by disabling that immune mechanism and thereby making the virus work better? So, I mean, these examples that I'm giving you are not publications as opposed to the 2 New England Journal papers I referred to previously that have demonstrated in a clinical trial. But I'm talking about studies that really are on the cutting edge that we think are going to be important in the future. The Beauty study and the gene and viral therapy in treating diseases like myeloma. I want to go to one last example, and I'm already out of time. Can I go a little bit further, Sandy?
You actually had till 2:30.
Sorry?
You had till.
Oh, okay.
We do want to, I think we're taking questions as we go.
Okay. I wanted to come to one last example that we've been extremely excited about. Last night we talked about the PSA in terms of screening for prostate cancer. And again, PSA is a very important test in its time. But what we've learned through a number of the large screening entities is this prostate-specific antigen, a technique that evolved, decades ago to basically diagnose prostate cancer. And again, with the caveats last night that if it continues to go up or it's very, very high, it's a very bad sign. But it should not be used as a widespread screening technique. And one of the things I mentioned last night in discussing PSA, as well as widespread use of mammography for breast cancer screening, is that this sort of the methods of 20 or 30 years ago, and maybe we need to sort of adapt to newer methods. And one of the most exciting approaches, which I think, and again, I'm giving examples that come out of Mayo, but they're examples coming out of all of our major cancer centers. I'm going to talk about the ones that are most familiar to me. But one that I'm very, very excited about, and I think judging by the response by FDA and CMS, both entities which, and we can say this, I guess, in Washington, they never really worked together, but they provided simultaneous approval of this test. And it's the test called the Cologuard test for colon cancer screening. And, for many years, colon cancer has been screened by using hemoccult tests, basically looking at the fecal sample, looking to see if there's blood in the feces. If there's blood in the feces, there is got to be a basis for that. Is it a colitis, ulcerative colitis, regional ileitis, or could it be tumor? In many cases, again, we know it's tumor that's the cause of the blood in the colon, and it comes out in the feces. But one of the newest tests that's evolved, and this came after many years, was to basically use genetic information in the fecal sample. And I have to say, many people at Mayo thought this was crazy, both from the clinician perspective as well as the geneticist perspective. How can you look at genes when you have the microbiome, all these bacteria growing in the colon that are chewing up DNA? How could you ever find a tumor signature in the fecal sample? But again, the persistence of this one group at Mayo looked at this as a potential way of avoiding techniques like doing the fecal hemoccult test, or the test that's used more typically to really screen for colon cancer, which is again doing a study where you have to either do a CT study, CT colonography, which was developed at Mayo, or again really looking at the colon using either sigmoidoscopy or colonoscopy as a method to basically screen for cancer. One of the problems we face in colon cancer screening also is that colon cancer is increasingly being found to occur on the right side of the colon. You know, the colon goes up as the ascending colon, goes across as a transverse, goes down as the descending colon. Most of us learned that at the beginning, most colon cancers were accessible by the sigmoidoscope, that you could look through the rectum, you could look up the descending colon, but more and more we're finding patients that have tumors on the right side or the ascending colon. And colonoscopy even can have a difficult time getting to that. If any of you have ever had the joyful experience of having a colonoscopy, you know how enjoyable an experience that is.
The drugs are great. Percent is my favorite. There I beg to disagree.
And it's, people can argue that maybe even the experience of having the actual colonoscopy is not as bad as having the bowel prep, which can be incredibly bad. But the Cologuard test is a really simple test that looks at 4 or 5 different genes, looks at methylated versions of the gene, looks at KRAS, looks at hemoglobin, and looks at a gene called beta-actin. And this was just published in the New England Journal back in May of this year, and it was the definitive study that was used by FDA as well as CMS to approve this study to be used for screening in colon cancer. And it basically was chosen as a substitute for colonoscopy because the statistics in terms of pickup, all patients that got the Cologuard test also got colonoscopy, also got a test called the FIT test, which is the fecal immunochemical test. And so they were able to compare the statistics of pickup of all 3. Colonoscopy being viewed as the definitive test because you got in there and were able to actually look at the colon. But what they found from doing this study is that the prediction was about 94 to 95% with using the Cologuard test compared to around 70% for using the usual FIT test, which is used for general screening. So it was much, much better in terms of doing screening. But again, it's what I implied last night is where we need to go with the PSA and where we need to go with breast cancer screening for some of the other the 4 big tumors that I talked about, but also potentially for other tumors as well, because we can screen now for these genetic markers in in something like feces that is excreted. And it's turned out to be a very, very easy way to do this screening test. FDA and CMS have approved it. CMS particularly has approved it for funding. It can be done once every 3 years. Really a fantastic way to follow up people that have an aversion to having the test done. And one of the things we feel is it's not going to actually get rid of gastroenterologists doing colonoscopies. We do 200 a day in Rochester, so we're pretty busy in terms of colonoscopy service. But what it will do is we feel it's going to actually bring more patients to be evaluated who really need to be evaluated. And potentially bring more people to the table who don't want to get cancer screening because they're not as brave as you were in terms of having the test done. So I think it's an important advance. I was mentioning to Mallory last night, one of the things that was very interesting, we have a large effort in the Native American population, and the Native American population in Alaska actually has the highest incidence of colon cancer in the country. And not only do they have a high incidence of colon cancer, but many of the natives are located in very small population groups throughout the huge state of Alaska, in population groups of less than 100, where they don't even have a doctor or even a nurse to be able to screen, yet we've been able to utilize the Cologuard test for screening of colon cancer very, very early. And studies that were presented at the DDW, the Digestive Disease Week meeting of gastroenterologists that was held in May, actually demonstrated the power of this test in that particular population. So we're very excited about using it in different populations, and really as a mechanism to do new types of screening. And even within the GI tract, we've learned, and you might ask the question, well, you're looking at the colon, what about the stomach and the pancreas and everything else that sloughs into the GI tract? Because we replace our gastrointestinal mucosa each day. Every 24 hours, we replace the mucosal lining inside our gut. But in tumors, they are actually sloughing cells even more frequently. And so the pickup is actually greater in terms of looking at DNA in tumors. And one of the things that we're doing now is actually looking at other tumors. So for example, in esophageal cancer, although my gastroenterology colleagues always say, oh, it's not going to hurt, but they've actually developed a technique where they have a capsule with a sponge that's included inside the capsule, and the capsule is on a string. Patient can swallow the capsule, it goes down into their stomach, and then the capsule breaks off, and the gauze or sponge basically expands, and sounds painful.
But it doesn't hurt.
It doesn't hurt. That's what they tell me. And then they literally bring this thing back up. They pull the string and they pull it back up through the esophagus, and well, the truth is there are not a lot of pain receptors inside. It sounds horrible, but it actually is probably not as bad. They're awake for it, yes. And but the thing is,
the other way.
The other option is, of course, to get endoscopy directly, and so endoscopy directly is not necessarily the most comfortable procedure. But what they're doing is that by pulling up the sponge along the cellular surface, they're actually able to get remnants of DNA fragments, and then they can screen for it. So that's now being looked at for esophageal cancer, for situations like Barrett's esophagus, where there's a high incidence of as a pre-esophageal cancer entity, that we can screen for it. And similarly, pancreatic cancer, and which is a deadly disease, as we talked about last night, and even stomach cancer. They slough into the GI tract as well. So we can look at the occurrence of DNA. So we're very excited about the Cologuard technology and that whole approach to not only GI malignancies, but also using this new genomic approach for diagnoses, which we think will make a big difference. And I didn't mention the other aspect that's really important. it's a much higher pickup for stage 1 and stage 2 disease, for the early stages of disease, and again, for the right-sided disease than otherwise occurs.
I'm just gonna interject here that this is a good time for questions.
Right, and I'm done. I've finished. So I'd like to open it up to any questions you have on what I've talked about, and also other things that I didn't touch on that you might have questions on. Steve?
So, just a quick question. Great talk.
Thank you.
Great overview. Really appreciate it. I'm wondering if you could now look at media coverage, media reporting of cancer over that same period of time, and tell us how you think that has evolved, for better or for worse, and especially where you perceive there to be deficits.
Yeah, I mean, I think we're moving into a new era. I was saying, I was talking with Sharon on the way here, who's from our media group at Mayo, that the direction, we're moving much more into digital. So we're much more onto Twitter. Mayo is very much involved in terms of its web-based information system, which is out there. But yeah, I think the media coverage. I guess we're sometimes paranoid being in the upper Midwest and the northern.
I don't mean of Mayo specifically.
Yeah.
I mean,
but just yeah, I know.
I think of the changing landscape of our businesses.
Sure.
Fewer resources, less professional training, which is why this is so
right,
great.
Right.
The BuzzFeedification of stuff.
Yeah, I mean, the really difficult thing is that there's so much information. It's evolving so fast, and it's almost hard for us to keep up with it. I mean, I cannot tell you how I've had to relearn everything. I've had to change, things that I learned when I was an intern and resident that are totally different, 180 degrees from how we would manage it today. So I think it's keeping up with the huge information. The biggest challenge is the evolving magnitude of information is so great. And to get that information out when the media resources are constrained in terms of their budgets, it's very, very hard to get the message out on a lot of these things. But I think the biggest thing I really want to convey today is the excitement. There's so much excitement. It's not that we're failing. I don't want to take a dig against my neurologic colleagues, but we were talking at Mayo before I left, and one of my colleagues who's a leader in cancer said, gee, I was talking to a leader in Alzheimer's disease, and I was saying, well, aren't you doing clinical trials on these things? They don't have the agents that we have. We at least can see differences, and they may not be prolonged differences, but the overall length and increase in lifespan after being exposed to tumors, there's such excitement in terms of these new approaches. So I think it's being able to get that message out, but it's the volume of information that makes it really so challenging. Yes, please.
I just wanted to get a feel for the timing. Like, clinical trials take forever, and for different drugs come out. Now you're saying that these specifically taking stuff from the actual patient and putting it into a mouse. Can that actually help the person in that time frame, or is that still?
Yeah, we're getting there slowly, but clinical trial is still what FDA expects in terms of getting an agent approved. I think one of the things we'll begin to see changes, so that when we recognize, for example, we don't need to repeat the effectiveness of a drug in another disease type. Just because it's a different disease type, we may not have to do a whole new clinical trial just of using a drug we used in breast cancer in leukemia, let's say. Using the genomic information, I think we'll be able to move a lot faster. We're still going to have to do a clinical trial. The N of 1 and the statistically well-powered study, both of them offer advantages, but they're at two ends of the extreme. It's somewhere in between that we need to go. Yes, please.
Hold on.
Oh.
We're formally out of time, so I'm going to wrap this up in one way. I'm going to give you the National Press Foundation mug, because everybody needs another mug. And thank you so much.
Okay.